Okay, I would like to thank Dr. Sharma, Dr. Keeney, Roxana, George, and everybody at Mount Sinai for an excellent meeting. Thanks for inviting me. So I'm going to start with Cto interventions. These are my disclosures. And I'll cheat a little bit. I'll show 3 of my cases, and then we'll go through data, and I'll ask you later on whether we should intervene on them or we should not. So quickly, 42-year-old, 42. Severe coronary artery disease, restenosis, had cabbage occluded, ejection fraction is preserved, recurrent chest pain. They attempted to open his circumflex, unsuccessful, seen by cardiothoracic surgery, and was offered TMR, which not many people are doing, and redo cabbage. So patient has debilitating angina, cannot walk, what to do? These are his quick things. Circumflex is gone, the big diagonal is gone. The right has a graft which is small but is patent, and Lima goes to a small LED. This is his anatomy. He's 42 years old. Case 2, I want you guys to remember these cases. Case 2, 52-year-old. Chronic smoking, that's the only risk factor. Progressive angina, positive stress test, and this is his anatomy. LED, occluded, collateralized, very well developed collaterals from the right coronary distribution. Think about it. Case 3, 79-year-old, EF is low, admitted with heart failure, had this diagnostic cath. Right is occluded, and circ is occluded, LED is occluded. So surgery, and the surgeon says, poor targets, medical therapy will be directed, this is direct quote from the chart, medical therapy will be directed towards LV dysfunction as well as secondary prevention, long-term prognosis is poor. All right, why do you do PCIs in stable angina? I will start with guidelines. We do it for prognosis, right? And if you go down the prognosis, if you have a large area of ischemia, which is greater than 10% of your LV, you have class 1. Even though it's B, you can see there's a whole bunch of observational trials that have shown that if you have large amount of ischemia, for prognostically, you do better. And we obviously do it for symptoms if they fail medical therapy, right? CTOs fit in this picture. So if you see here, from his excellent study, you can see if you have scar tissue and if you have less than 12.5% ischemia, you do poorly with revascularization. You need medical therapy. But if you have greater than 12.5, you see the diverge, and early revascularization is very, very important, and that's where the guidelines come from. How about our patient with cardiomyopathy that I showed you? You can see this is the STITCH trial, and then the extension study of the STITCH trial published in the New England Journal, and you saw they randomized medical therapy in these patients with ischemic cardiomyopathy to cabbage, and you can see there was 8% absolute reduction with cabbage revascularization than medical therapy in these kind of patients. We see a lot of these patients, you know that. Quickly, chronic total occlusion on ICD firing. In ischemic cardiomyopathy, obviously, if you have more CTOs here versus no CTOs, and you can see the significant amount of firing. Not only from scar tissue, but even if well-developed collaterals with borderline ischemia, they have a large amount of ICD firings. Looking at registries, I'll show you registries, then we'll talk about randomized trial, because I'm sure Praveen is going to show you these randomized trials. And everybody asks about randomized trials. You know what percentage of guidelines we have for revascularization are based on randomized trials? Only 15%. So think about that number, okay? All right, so if you have CTOs, you have failed revascularization, you have worse outcomes, which is very similar to not doing it at all, and you have best outcomes with complete revascularization. This was the UK registry. The SCAR registry will show you the same. CTOs have worse mortality than non-CTOs, and if you have successful, you have better outcomes than non-successful. Look at the Syntax trial. If you look at the 4-year post-hoc analysis, if you had complete revascularizations, your outcomes across the board were much better as opposed to incomplete revascularization. And you know the most common reason for incomplete revascularization in Syntax was CTOs. So how about randomized trials? Randomized trials are hard to do in CTOs, okay? There is a big, big selection bias. I'll show you the trials. You can see here there are 3 randomized trials that Dr. Sharma actually showed earlier on. And Explore trial was an MI patient who had a CTO. He did within a week of PCI, and they looked at LVEF and LV diastolic volume. There was not much change. But if you look at those patients with a subset of LAD occlusion, they actually had improvement in LVEF, okay? Decision CTO, Euro CTO took forever to enroll. They wanted to enroll close to 1,000 patients. They ended up enrolling about 800. It was grossly underpowered. And since it took so long, there is a selection bias. Most people who were symptomatic and high-risk ischemia, they were not enrolled. They were usually lower-risk patients. So this is the decision CTO. I'm sure Praveen is going to show you, so I'm not going to jump over that. Only 65% of the planned patients, we needed 1,284. It was underpowered. There was high crossover rate. It took 6 years to enroll. So I'll jump over these things real quickly. I'm not going to go over this, and I'm going to show you the meta-analysis. If you look at CTO, PCI, and reduction in mortality in randomized trial and in registries, you can see across the board here that the cardiac death and all-cause death were statistically better with revascularization versus no revascularization. So let's look at our case. That was our first case, remember? He had circ, they had attempted to PCI but are unsuccessful. We open it up, patient's angina improved, patient can now go back to work. Even though if you did ischemia on this patient, I think it may be that not much ischemia, but there was viable myocardium and patient was symptomatic. So this we did for symptom improvement. Patients did not get better on medical therapy and Renexa. How about this young patient that we saw? LAD occlusion, large amount of ischemia and unstable angina. These are the patients that have improved in death and MI because it's a large amount of burden of ischemia. How about our last patient? Ischemic cardiomyopathy, they said medical therapy clearly indicated. We're going to send him home because the prognosis is very poor, right? So we did viability study. You can see all areas are viable except for the right. The right is messed up anyway, so we don't want to attempt it. So what we did is we opened up his LAD. We put a stent in the proximal circumflex. Distal runoff was poor. We just did chocolate balloon angioplasty, and you can see his myocardium is very, very happy. And so this is real. So look, the clinic referring physician said we had the pleasure to see the patient. He continues to feel well. Look at the ejection fraction. He can mow his lawn. Look at the ejection fraction. It's 40%. And think about 20% and being admitted every other month than this. So when it comes to CTO interventions, successful recanalization in selected patients, the patients that I showed you is better. So thank you very much.